Thank you, Nirav. Good evening, everyone. We are here for the yet another scientific session by Samarth Life Sciences, which we all know as OSMOSIS, a masterclass on prostate cancer. Myself, Prasad Amle. I am Assistant Product Manager at Samarth Life Sciences. So, as we all know, Osmosis is a scientific platform where we exchange the insights, clinical experiences on the different sets of cancers. So, without wasting any time, I will start the session. So, let me introduce my colleague, Miss Anjana Yadav, who is a manager, medical affairs at Samarth Oncology. Over to you.
Thank you so much, Prasad, for the introduction. Again, good evening, everyone. I would like to welcome all the speakers, panelists, delegates, and Team Samarth. I am Anjana from the medical team of Samarth Life Sciences Private Limited. On behalf of the organization, I am truly delighted to welcome you all for the today's webinar, which we know as Osmosis. Now, this osmosis is on prostate cancer. This scientific initiative, which is presented by our oncology division, that is OnQuest, reflects the summit's continued commitment to advancing education and dialogue within the field of oncology. Through this platform, we aim to create meaningful opportunities for scientific exchange and discussion on topics that shape the future of cancer care. We believe that osmosis is not merely a scientific forum, but also a powerful metaphor for knowledge dissemination, a network that connects ideas, expertise, and innovation. The process of continuous learning is indispensable, particularly in the ever evolving landscape of oncology, where staying informed and adaptable is vital for improving the patient outcome. Today's program is also a testament to our shared dedication to scientific excellence and our collective mission to deliver the best possible care to the patients. The focus of today's session is a masterclass on prostate cancer. We are honored to have with us our eminent experts who will share their valuable insights and clinical experiences on this important topic. Before we start, let me give you a brief introduction about our company profile. Samarth Life Sciences. Samarth Life Sciences is an innovative life science company that researches, develops, manufactures, and markets a broad range of life saving critical care products and other drugs. With our vision to emerge as an innovative premier healthcare company, we are committed to deliver healthcare products with the highest level of operational excellence. Since its inception in the year 1963 by Mr. Gunwantlal Shah, Samarth Life Sciences has been a prominent player in the pharmaceutical industry. The company specializes in manufacturing an innovative and differentiated portfolio of pharmaceutical products, emphasizing unique formulations and cutting edge solutions to meet the diverse medical needs. Samarth Life Sciences operates through 14 therapeutic specialty divisions, each focusing on specific areas of healthcare to provide targeted solutions and expertise across a broad range of medical conditions. OnQuest is one of the division that caters to the oncology specialty. Samarth Life Sciences is a WHO GMP and ISO 9001 certified that ensures the highest standards of quality and manufacturing practices. We export over 250 products in over 70 countries, demonstrating our global presence and commitment to serve diverse markets. We are proud to share that Samarth Life Sciences has received significant accolades and recognition, reflecting its excellence and influence in the healthcare sector. With this short brief about us, we would like to initiate the scientific program. For this, I would like to introduce the program director for today's session, Dr. V. Arun Ramanan. He is Ramanan sir. He is a senior consultant and clinical lead at Medical Oncology, Glenangles Hospital, Chennai. He's the program director for the today's session. And the speaker, our first speaker would be, next slide please. Our speaker for the topic that we will be having today is GnRH agonist or antagonist for prostate cancer. And the speaker on this topic is Dr. V. Arumugam Sir. He is a consultant medical oncology, Sri Velsant Cancer Care Center, Tirunelveli. So with this, I would like to hand over the session to Dr. Arumugan Sir. Arumugan Sir, are you there?
Yeah, I'm there.
Over to you, sir.
Yeah, thank you. Dr. Arun Ramanan.
Yes, sir.
Yes.
Nice to meet you.
Hi.
Good evening.
Yeah. Can I
Hi,
start?
Arumugam.
Or,
Yes. You
sir,
can.
will
Yes,
start
sir.
with me. Okay.
Nalla
You
irukka.
can start.
You
You
can
can
start.
start your.
Yes, you can kickstart.
Yes,
Okay.
sir. You can start your fire.
Thank you. Thank you. So, the organizers, please share the slides.
Sir, the slides are visible to you, no, sir?
Yes, yes.
You can.
Yeah, yes. You can move to the next slide. Yeah, thank you. Thank you for giving me this opportunity to discuss about the agonist and antagonist for the uh, prostate cancer, LHRH, GnRH agonist and antagonist. So the prevalence of prostate cancer is the second most common cause of cancer and the sixth leading cause of cancer death among worldwide. It is about 1 in 6 are diagnosed with the prostate cancer in US. But the incidences are less in our area. So the prevalence of prostate cancer, recent data from the National Cancer, next slide, National Cancer Registry Program indicate a significant escalation, projecting prostate cancer to ascend to the third most common cancer among Indian male by 2022, with an estimated incidence rate of 6.8 and a cumulative risk of 1 in 125 men. So the current burden of prostate cancer in India is substantial, with an age-adjusted years lived and with the disability of 6.5 per 1 lakh male, ranking third highest among males, and age-adjusted disability adjusted life year is 46.9 per 1 lakh male, and ranking it as a seventh highest among males. So the burden of prostate cancer in India is expected to rise further due to the population growth and increasing life expectancy and an increase in the proportion of aging males in the country. So it is expected to reach 47,068 incident cases by 2025. So the next slide. So prostate cancer, the diagnosis and the treatment. So usually the patient is having the prostatic symptoms. If the prostatic symptoms is there, you have to examine with the digital rectal examination. And if patient is having high PSA, proceed with the prostatic biopsy. If there is no cancer, or it may be a low grade, or it may be a high grade. Low grade, please put under the active surveillance, and high grade can proceed with the radical prostatectomy or radiation therapy or ADT. And the patient may progress to the castration-resistant prostate cancer in later. Next. So ADT means androgen deprivation therapy. Why needed and how to start and when to start. Next slide. So ADT is any treatment that results in suppression of androgen activity, either by surgical or medical. Next slide. So the surgical, how to proceed with orchidectomy, and the medical, there are multiple options are there. Estrogen, LHRH agonist, antagonist, non-steroidal anti-androgen, steroidal anti-androgen, and androgen synthesis inhibitor, maximum androgen blockade, and other newer substances. Next slide. So the mechanism of action of GnRH agonist differs significantly from from that of the agonist. So agonist has increases the agonistic action on the GnRH and increases the FSH and LH surge, and in between there may be some microsurges and FSH suppression, but not maintained long term. That is the outcome. And in antagonist, we have a immediate suppression of FSH and LH, and there is no microsurges and the prolonged suppression of FSH and LHS and testosterone. So next slide. The Dagarelix, to discuss on Dagarelix, there is a randomized phase 3 trial comparing so Dagarelix with Leuprolide, and Dagarelix 240 milligram on day 0, it's a start dose, and the maintenance dose with either 80 milligram or 120 milligram. The Leuprolide is given as 7.5 mg. So the the inclusion criteria, previous or current hormonal treatment not allowed except as neoadjuvant or adjuvant to curative intent, and anti-androgen flare protection to agonist arm at investigator discretion. And primary endpoint is testosterone level less than or equal to 50. Next slide. So the primary endpoint, cumulative probability of testosterone of less than or equal to 50 nanogram per deciliter. And secondary endpoint, proportion of patients with the testosterone surge and proportion of patients with the testosterone less than or equal to 50 nanogram per deciliter at day 3. And percentage change in the PSA from baseline to day 28 and time to PSA failure. And frequency and severity of adverse events and the frequency of PSA progression. These are the secondary endpoints. So next slide. So the Dagarelix significantly reduces the risk of PSA progression or death, and also significantly more men with the baseline of PSA of more than 20 nanogram per ml, and have a PSA progression when treated with the Leuprolide versus Dagarelix. So compared with the LHRH agonist therapy, Dagarelix offers faster. Next slide. Faster castration onset and PSA suppression with no risk of clinical flare, and longer PSA progression-free survival, especially in those with the greatest risk of progression. So next is the CVD risk. So ADT, next slide. ADT and risk of CVD. So ADT is associated with increased risk of cardiovascular events. So LHRH agonist linked to increased CVD morbidity compared to orchidectomy. So men with the history of CVD most at the risk. So Dagarelix has a distinct mechanism of action to LHRH agonist. So risk of CV event may also be different. So pooled database analysis, next slide. The risk of CV event in men receiving agonist and Dagarelix was assessed in a pooled analysis of 6 randomized phase 3 trial. So these patients are the 1,491 patients with the Dagarelix and 837 patients with the agonist. Agonist either Goserlin or Leuprolide. The baseline cardiovascular disease history is 31% with this Dagarelix arm and 29% with this agonist arm. So CVD history means it may be a ischemia or coronary artery disease or frank myocardial infarction or cerebrovascular accident. So those, next slide. So higher incidence of CVD event with the LHRH agonist than Dagarelix in all patients. It's about 2.8% with the Dagarelix and 4.4% with the LHRH agonist, and death is about 1.3 versus 2.6. Next slide. So the lower risk of CV event or death with the Dagarelix. Next slide. So those who are having baseline CV history, so it is also shown an increased risk with the agonist. So in any CV event, the Dagarelix is about 4.5%, 9.5% with the agonist, and death is about 1.9%. Those who have previous CV history, and 5.3% with the LHRH agonist. Next slide. So lower risk of CV event or death with Dagarelix in men with baseline CVD. So summary, when treated with, next slide, treated with Dagarelix compared with the GnRH agonist, patients with the pre-existing CVD had significantly fewer CV event during the first year of treatment and had a relative risk reduction is about 8.2%. Next slide. So it is a HERO trial. It's a study on Relugolix. So a multinational phase 3 randomized open label parallel group study. So men with advanced prostate cancer, 2:1 randomization with the Relugolix and Leuprolide. So Relugolix 360 milligram on day 1 and 120 milligram orally once a day. And Leuprolide 22.5 milligram subcutaneous injection every 3 months. The primary endpoint is assessed at 48 weeks, and the testosterone recovery subgroup also analyzed. Next slide. The primary endpoint is sustained testosterone suppression rate. That is defined as the cumulative probability of testosterone suppression to less than 50 nanogram per deciliter while on study treatment from day 28 through week 48. The secondary endpoints are testosterone suppression rate on day 4 and day 15, and PSA response rate on day 15, and the profound testosterone suppression rate on day 15. The testosterone recovery sub-study, there's a cumulative probability of testosterone recovery to 280 nanogram per deciliter at 90 days follow-up in 184 patients who completed 48 weeks of treatment and who did not receive subsequent androgen deprivation therapy for at least 90 days after discontinuation. So these are the endpoints. The results are, next slide. So relugolix achieved sustained testosterone suppression to less than 50 nanogram per deciliter. The sustained castration rate of testosterone is high with relugolix than leuprolide. Next slide. So the mean testosterone level among all patients, the rapid testosterone suppression with no initial surge and sustained suppression throughout the study. The sustained castration rate of relugolix was statistically superior that of leuprolide. So the rapid testosterone suppression as early as, next slide. So as early as day 4, suppression is greater number with the relugolix group than the leuprolide. Next slide. So rapid testosterone suppression as early as 4th day with relugolix, but in day 15 it is about 98.7% in leuprolide group. So PSA levels, next slide. Like a PSA level lowered average by 65% 2 weeks after administration of relugolix, and 83% after 4 weeks, and 92% after 3 months, and remained suppressed throughout the 48 weeks of treatment. So it has a demonstrated PSA reduction from baseline average of 104.2 nanogram per ml. So the profound testosterone suppression was achieved with relugolix. Next slide. So relugolix achieved profound testosterone suppression defined as testosterone concentration of less than 20 nanogram per deciliter. So another point, another subgroup analysis is the testosterone recovery. Next slide. Testosterone recovery. So the most patients achieve testosterone recovery in relugolix group. So the percentage of patients with testosterone recovery at least 280 nanogram per deciliter at 90 days was 54% in relugolix group and only 3% with the leuprolide group. So the safety of relugolix, overall incidence of adverse events was consistent across treatment. Next slide. So the safety with relugolix, the overall incidence of adverse events was consistent across the treatment group, and the fatal outcome were reported 1.1% with the relugolix group and 2.9% with the leuprolide. Incidence of major adverse cardiovascular event was 2.9% in the relugolix and 6.2% with the leuprolide. So safety, when this looking at this Kaplan-Meier, next slide, Kaplan-Meier estimate that the incidence rate were consistent with a 54% lower risk in the relugolix group than the leuprolide group. Safety, next slide. So the major adverse cardiac event, patients with a history of major adverse cardiac event, the odds of having this major adverse cardiac event were 4.8 times high with leuprolide and than the relugolix. So summary, the GnRH antagonist, dagarlix or relugolix may be associated with the lower incidence of CV even than the agonist. And the difference in the risk appears likely to be due to differing mechanism of actions, the type of ADT. The risk of CVD should be carefully assessed prior to using ADT and the risk minimized where possible. In the presence of CV risk, GnRH antagonist may be the preferred agent. And in the absence of CV risk, probably little to choose between LHRH agonist and antagonist. So that's all. Thank you.
Thank you so much, Doctor, for sharing your valuable insights. Now we will move on to our next case presentations, and we'll continue this scientific journey with another interesting case. So there are two case presentations that we will be going through today. The first case is on castrate resistant prostate cancer. How do I treat today? And for this case presentation, the moderator is Dr. A. Ravichandran. He is a consultant medical oncologist, Sri Ramchandra Medical Center, Chennai. And the panelists for the case presentation are Dr. Prem Kumar Devdos, consultant medical oncology, Kaveri Hospital, Chennai. Dr. K. Kavithendral, consultant medical oncology, Noble Cancer Care, Tanjavur. Dr. Biju Azre M, consultant medical oncology, Dr. Azra's Cancer Care, Kanyakumari. Dr. Karthik S, consultant medical oncology, Trinavelli Medical College, Tirunelveli. Over to you, Dr. Ravichandran, sir.
Yeah, thank you. At the outset, I would like to thank Kamath Oncology for giving this opportunity. So I would like to welcome all our panelists. So today I'm going to discuss about like how to treat castrate-resistant prostate cancer. So I'll share my slides. Oh, you are saying okay. I would like to share my screen. Is it okay?
Yes, sir.
Sir.
Basically, the prostate cancer, the natural history starts from it's like a localized disease, then it spreads to nodes, and then other metastatic sites like bone, liver, etc. So it start like from local disease, then move on to regional disease, then either it spread into like hormone positive, that is castration sensitive metastatic prostate cancer, or it is non-metastatic castrate-resistant prostate cancer. And finally, all the patients will end up in metastatic castration-resistant prostate cancer. So uh, the whole idea of treating prostate cancer is to delay this progression from localized disease to metastatic castration-resistant prostate cancer. So today I'll be dealing with CRPC. So basically we can split this into non-metastatic CRPC and metastatic CRPC. Basically, Dr. Karthik sir, how do you define like CRPC, the castration-resistant prostate cancer?
So we routinely monitor with the serum PSA levels, sir. So whenever there is, in spite of castrate levels by either surgical or medical, but still we have a PSA rising, we go on with the term like castrate-resistant prostate cancer, sir.
Yeah. So the castration levels are like, as I mentioned by previous speaker, it is 50 nanogram per DL. So in spite of that, the disease progresses. That is PSA. It can be like a rise in PSA or a disease progression either
Yes.
to nodes or bones or visceral disease. So we call it as CRPC. So we have
Yes.
two scenarios in this: non-metastatic CRPC and metastatic CRPC. Prem sir, like how would you like to proceed, sir, when you find like a CRPC patient, sir? To begin
Yeah,
with, how
that's right. As you said, we have both non-metastatic and metastatic. So considering the non-metastatic, as Dr. Karthik rightly pointed out, it is usually, the raising PSA value that bothers us. So, but I would watch the PSA values, but then I'll be skeptical. I won't be very hasty in starting my treatment. I would probably look at the doubling time because that is more important.
yes,
Because there is a
doctor.
possibility of observation here. Yes. So if it is less than 10 months, then probably I would intervene. If it's more than 10 months, the PSA doubling time, I mean,
Yes,
then
sir.
probably observation will be my choice, Ravi.
Yes, sir. Yes, sir. So the PSA doubling time is key here. So more than 10 minutes indicates it's like indolent course of the disease, whereas less than 10 months indicates aggressive nature of the disease. So everyone would like to intervene whenever there is a PSA doubling time is less than 10 months. Uh, Dr. Biju, sir, when would you like what are the drugs would you like to start in non-metastatic CRPC?
So in this scenario, for non-metastatic castration-resistant prostate cancer, we have only 3 approved agents. It is either apalutamide or darolutamide or enzalutamide. All 3 has shown significant benefit, and any of these drugs can be used interchangeably. And these are the only drugs which are available in this spectrum of disease to be treated. So I can choose any one according to the comfort which I have with these drugs.
Okay. Do you have any preference for any molecule?
With respect to the hazard ratio, all 3 things has shown significant hazard ratio, and more benefit is seen with the apalutamide. And I think we can use any of these things interchangeably as per we are comfortable with the drugs which you are using. I would go with enzalutamide because I'm been comfortable with the drug, but apalutamide would be the better choice because it has shown the maximum benefit.
The other point I would like to add is based on the side effect profile, we can choose, and based on the comorbidities of the patients also, we can choose either of the drugs. Coming to like metastatic CRPC, Dr. Kavi, would you like to do any molecular testing for this patient metastatic setting? Dr. Kavi is joined or not?
Sir, he is not joined.
No, sir.
And, okay. Then Karthik, sir?
Yes, sir.
Would you like to do any molecular testing in a metastatic CRPC setting?
Yes, sir. We will definitely go with a BRCA testing or HRD.
Like, I mean, like when you do upfront, or you this is the test on the later setting, like post, second line, third line?
Maybe in the later lines, sir.
Okay. Any reason for that, sir? Like, why do you want to do in the later lines?
Because it is basically the indolent disease, and we have more options, other options also.
Yeah, absolutely reasonably one, sir. So this already we discussed this one. So castration resistant definitions, and the testosterone level is less than 50 nanogram per DL, and based on the PSA doubling time, it is more than 10 months. So monitoring is the preferred one. If it is less than 10 months, so obviously go for intervention, either using apalutamide, darolutamide, or enzalutamide. The metastatic free survival by using all these 3 areas reported in the trials, Aramis, Prosperous, or Spartan. So all show like roughly around 18 to 20 months of metastatic free survival, with darolutamide, apalutamide, and enzalutamide. As somebody was pointing about the hazard ratio, it is very impressive for apalutamide, 0.28. And for enzalutamide, 0.29. It's close. Whereas for darolutamide, it's 0.41. Coming to the overall survival about of all 3 agents, so it also showed like a benefit of adding overall survival with impressive numbers. Again, if you look at hazard ratios, it's more impressive for enzalutamide, it's 0.73. 0.69 for darolutamide for overall survival. So coming to various options for treatment of metastatic CRPCs. So the first one being like a Ciplicel T. It is a dendritic cell vaccine, usually used in pre or post docetaxel setting. It is given like around 15 million cells of CD45 autologous cells, given every 2 weeks for at least 3 times. Usually, it is preferred for CRPC patients with minimal symptoms or asymptomatic patients. And it is contraindicated in patients requiring narcotics and liver metastasis. It gives of modest benefit of around 4.1 months of overall survival. Coming to the ARBs, that is androgen receptor blockers, abiraterone. So it can be used in the pre and post docetaxel setting. The convenience is oral. It should be taken empty stomach, because if you take the food, it will have erratic absorption. So that's why there is a trial comparing the 1000 mg versus 250 mg, where it just showed non-inferiority of the dosaging, 1000 versus 250. And contraindications like severe liver dysfunctions, hypokalemia, and heart failure. It also gives modestly around 4 months of 4.5 months of overall survival benefit. Coming to the enzalutamide, it is also can be used both in the pre and post docetaxel setting. Conveniently, it can be given oral, available in 40 mg, 80 mg, 160 mg. The main contraindication is seizures. It can cause CNS side effects. So whenever the patient gives a history of seizures, so we have to avoid this molecule. It also shows like survival been close to 4.8 months as like your abiraterone. And coming to chemotherapy drugs, docetaxel and cabazitaxel, uh, it's given like once in 3 weeks. Docetaxel around 75 mg per meter square. Contraindicated patients with liver dysfunction and cytopenias, and it gives like a modest OS been around 2.4 months. Same with the cabazitaxel. Initially used as like around doses around 25 mg per meter square. With this, most of the patients were not able to tolerate the drug. So in the practical, most of us, I think, use only 20 mg per meter square. Again, contraindication is liver dysfunction, cytopenias. Coming to the last agent, that
I'd
is
like to add up on points.
yeah, yeah, yeah.
There is a non-inferiority trial named Prosilica. It has mentioned that it is a 20 milligram per meter square is non-inferior to 25 milligram per meter square in patients already exposed to docetaxel.
Yeah, yeah.
Okay.
The last drug is radium-223, usually used in the patients with only bone metastasis. It also gives modest survival benefit of around 3.6 months. So these are all the various options. Chemotherapeutic agents like docetaxel, cabazitaxel, and anti-androgens, that is abiraterone, enzalutamide, and immunotherapy vaccines, that is Iplicity, radium. And then if you have like patients with deficient MMR or MSI high, where we can use immunotherapy, pembrolizumab. And then post all this therapy, we can use PRRT with the lutetium-177. And if you have like a somatic HR gene mutations, there is option of PARP inhibitors as well. The other non-FDA approved agents like adding platinum chemotherapy and phosphorescent. Prem sir, do you have any experience with this platinum chemotherapy and the phosphorescent, sir?
No, not at all. Platinum, yes. Once, of course, we have, because once we lost all options, we did a re-challenge with docetaxel, and when we add platinum. So that was also because we had checked the patient for BRCA. So BRCAness was there. So I don't know how far I could extrapolate that, but we did that for about 5 to 6 cycles. The patient actually responded, because this was a patient who had been treated with docetaxel, abiraterone, and enzalutamide, who later progressed. Then that time we did not have facility to, we were not able to look at the MSI or tumor mutational burden. But even though that's very low, the percentage in prostate is very low. We all know that. But phosphostrol, no way, no experience. I don't know if the other panelists have any experience on that.
Others can comment when even used phosphorescent.
We
No,
don't have experience of using phosphostrol, but platinum we used to combine if there is some neuroendocrine features, if the patient is progressing on EDT, and if there is a predominant neuroendocrine component, then I think we can
That's
use
correct.
platinum as part of the
With
chemotherapy.
etoposide also we do combine neuroendocrine tumors. Yes.
Yeah,
That's
on
true.
one, I
Yes,
have
sir.
used when no other options were there, but we have some hormonal imbalance will be more with on one. Vomiting will be very extensive, and so, but there was a time when we used even antifungal agents also, because it was all anti-steroidal. So that was what was the initial plan. Okay, platinum, if at all we use in a neuroendocrine differentiation, we might use that in platinum. And on one, maybe 15 years back.
Actually, I also using nowadays when you exhaust all other options. So I'm giving phosphostrol 120 mg once daily. I can see there is some reduction in PSAs, so we can able to like prolong the PFS of around 3 to 4 months. But so vomiting, none of my patients they complain vomiting, but tiredness and estrogenic side effects that were they were mainly complaining of. Okay. The
I
other
too have
indication
seen
for
my-
adding platinum.
I was trying to say that I too have seen my teachers using this phosphostrol. The problem is gynecomastia, which usually happens.
Yeah, fine.
And I have seen
Yes.
them giving prophylactic radiation to the breast to take care of this gynecomastia with the Holvan.
Okay. The other indication to add like a platinum is like along with cabazitaxel. So whenever you have a high burden of disease with low PSA and high LDH values, high CA, and then lytic lesions, and as you told, like a neuroendocrine differentiation. So in all these indications, platinum doublet is recommended. But I don't know how the patient will be able to tolerate down 3 to 4 lines of all these therapies.
Right.
So coming to the outlines. So first, how to select a first line treatment for metastatic CRPC, and then second line, then how to sequence with various agents available, and then finally discussion on the role of targeted therapies. Dr. Biju sir, which agent like the chemotherapy or androgen blockades, which one would you like to choose in a first line setting?
There are several factors which we have to consider before selecting it. So one is the symptom burden of the patient and the disease burden, whether it is only bone confined disease or bone plus soft tissue or just a soft tissue disease, then the comorbidities of the patient, and then the previous treatment which they have taken in the adjuvant setting. So these are the factors as well as the life expectancy of the patient. So these has to be considered before deciding the first line management of metastatic castration-resistant prostate cancer. For a fit patient with a high volume disease, I think we should try to use docetaxel. And other patient who is not that fit or has the moderate to low volume disease, I think we can go with abiraterone or enzalutamide type of agents.
Yeah, absolutely well taken. So there is some concept called like the second line setting. Most of the patient may not be in a good shape, so like most of them won't be able to tolerate chemotherapy. So my teachers used to say like we should use chemotherapy in the first line, then later on we can reserve these hormonal agents. So what's your thought on sir, like Prem sir, on this?
No, that used to be the thought process earlier. But then once again, we should consider the tumor burden and the visceral metastasis, especially if symptoms. If you require the symptoms to be addressed, very quickly, then probably docetaxel would be the choice. And
So for
especially
high
those in
volume
those
disease, it's
high
no
volume
question. It's
disease.
only chemotherapy only if the patient is fit. So I'm
Yes.
talking for like a low volume disease patients.
Low volume disease, I'll be really skeptical. I normally do not use first line unless the patient is really fit with no comorbidities. Then I think you're talking about the docetaxel in combination with abiraterone.
In the second line settings. What if the patient general condition is not good to use the docetaxel?
Second line, yes, I know your thought process. First line, always the performance state is a lot better than second line. So it's probably wise to use docetaxel, but we generally reserve docetaxel in our practice for a high volume, first line. Otherwise, it is usually, progressed, then we fall back on taxane. And when we're looking for very quick responses, then yes.
Okay. Dr. Karthik, sir, like what is the definition of your definition of high volume diseases? Like, how do you classify the patients like high volume and low volume disease?
You are asking definitions to me alone. So it's like two criteria we have.
Do you follow that charted criteria?
I'm
Same like
charted. Usually, it's like if it is like a metastatic castration sensitive, it's more like for a hormone receptor positive breast cancer, where we have so much of volume of disease. We go with like missile crisis. No, we go with chemotherapy, and in my government setup, we go with IV docetaxel as first choice. So then we go with next options like abiraterone acetate and enzalutamide and all. And as already mentioned, we should take into account so many factors as factors of the patient.
Yeah, sure. So Dr. Biju sir, like what is the like sequencing? What is the ideal sequence you follow, sir? Is there any preferred sequence for him with various agents available?
Yeah, I mean, as I said already, I mean, I would try to give docetaxel in the first line. Also, for one of the reasons you told that patient might be fit at the upfront treatment. And especially if the patient is having visceral disease or more than 4 or 5 bone metastasis disease, I think, and if the patient is having no contraindication to taxane, I think I'll be giving chemotherapy as the first option, and then keep the other agents for the second line.
Okay. So is there any like opinion that ARV V7 splicing variant to use hormonal agents? Do you routinely check for that?
No, I don't do that.
Any other panelists?
I think that is upcoming, but I don't think any of us do that routinely. At least in our centers, we don't. That ARV7 you're talking about, correct?
Yes, sir. So it is a resistant for like hormone therapy. So those patients are like suitable for giving more chemotherapy than hormonal agents.
Hormonal agent, that's right. But I don't know. We have not done any. We have not tested for that. We don't go by that.
Okay.
It's only the sequencing. Yes, if it's a hormone, then probably a taxane in between, sandwiched between 2 ARs. That's a sequence we generally follow.
So what about sequencing like two hormonal agents like abiraterone versus enzalutamide or enzalutamide post enzalutamide abiraterone?
Yes, definitely. The disease volume is not too high. For instance, if we had started the patient on abiraterone and you get a good response for a while and then the patient progresses, but with still not high burden visceral metastasis requiring immediate response, then I would always fall back on enzalutamide if there's no contraindication or something. Especially if the patient's not prone for seizures. Yes, I do give enzalutamide. Reserve my taxane for later lines.
No, please. Okay. So selecting first line treatment for metastatic CRPC. So if they use only ADT in the hormone positive, that is metastatic hormone sensitive prostate cancer. So we have three options like chemotherapy and other hormonal agents like abiraterone and enzalutamide. And if they use like ADT plus docetaxel or ADT plus abiraterone, then the other agents are like docetaxel. Post abiraterone we can use docetaxel, and post docetaxel we can use hormonal agents like abiraterone and enzalutamide, and cabazitaxel also an option for post docetaxel.
Post docetaxel.
So here is one 62-year-old gentleman is non-diabetic, hypertensive. So he was diagnosed with CF prostate in 2018. His Gleason score was 9 with a PSA of 545. He had extensive bone and nodal metastasis. So he was given only ADT. With that, his PSA has come down to 1.9. In the month of November, he became like symptomatic for bone pain, and his PSA rose up to like 93.92. So what are the options for these patients? So as I told, like we can use either of these things, docetaxel, abiraterone, and enzalutamide. So it depends upon the mainly symptom of the patients. So the data comes from TAX 327 and SWAG 9916. So where they compared docetaxel 3 weekly with mitoxantrone plus steroids. So we can see like there is a OS benefit of like only 2.4 months with a 3-weekly docetaxel. With weekly docetaxel, the higher rates of side effects with a modest benefit of OS. So the second case is it's an 8-year-old gentleman. Is a metastatic prostate cancer diagnosed in 2017 with a Gleason score of 8 and a PSA of 2,794. His PSMA PET showed nodal and bone metastasis. That is Degarelix. It was started on Degarelix. With this, PSA has come down to 33. But there was a rising in PSA of 92. But this patient has like poor performance status of multiple comorbidities like diabetes, hypertension, CAD, and with the ejection fraction of only 40%. So in these patients, the may not be suitable for chemotherapy. So we can offer hormonal agents, enzalutamide or abiraterone. As the patient is having like EFF 40%, generally abiraterone is contraindicated for patients with heart failure. So the enzalutamide would be the better option for this patient. So coming to data for enzalutamide in first line setting, uh, the patients with metastatic CRPC were randomized to receive either 160 mg of enzalutamide versus placebo. Endpoints being overall survival and the radiographic progression-free survival. So it showed like a significant benefit of radiographic free progression with hazard ratio of 0.861. It is very, very impressive. And there is a OS benefit of around 2 months with a hazard ratio of 0.70. Coming to the data for abiraterone, so the patients were randomized, 1:1 patient, 1000 mg of abiraterone along with the prednisolone of 5 mg BD, compared with the placebo. So the endpoints being a radiographic progression-free survival. The other endpoints being overall survival. So it also showed OS benefit of around 5.2 months. Coming to choosing the treatment like a post-docetaxel progression. So as we all told, like we have 3 options, either cabazitaxel, abiraterone, and enzalutamide. So the data for cabazitaxel comes from TROPIC trial. Initially, they used 25 mg per meter square as compared to mitoxantrone. So it showed like a modest OS benefit of around 2.4 months. And the data for abiraterone comes from this COU-AA301 trial. It also showed OS benefit. All the trials showing like OS benefit of around 4 months for hormonal agents and 2.5 or 2.4 months for chemotherapy. So this is a slide on like how to sequence the agents. So there's a systematic review of 13 published retrospective studies where they compared like a 1-year OS rate, a post-docetaxel setting. So the topmost curve showed like sequence of cabazitaxel, then followed by like a anti-androgen therapies. So that showed like a highest OS benefit and compared to ART versus cabazitaxel. And there was a poor outcome when you use sequencing of ART versus ART. So what are the emerging therapies in this setting? So that as I told, like PRRT with the lutetium. So patient who has PSMA avid disease, good candidates for this lutetium therapy. The only disadvantage is like lutetium will cause ablation of our bone marrow, that is, it can cause fibrosis. So they're prone to get cytopenias. So we may not be able to give chemotherapy post lutetium therapy. No. So it also showed like some OS benefits are close to 4 months. So other agents like genomic alterations, like HRR, PARP inhibitors with the concept of synthetic lethality, and then deficient MMR to use immune checkpoint inhibitors. Other tumor agnostic markers like NTRK agonist, NTRK antagonist, sorry, entrectinib and so there is one study, it showed like a germline mutation in the DNA repair genes accounting for around 11.8%. So most of it accounts for like BRCA2 around 44%, followed by ATM gene 13%, and check 2 genes around 12%, and the BRCA1 only 7%. Sir, Prem sir, do you routinely checking for this mutation like germline, somatic? What is your
Now the
preference?
germline BRCA1 and 2 and ATM and all these, usually initially we were checking only like third line or after progression, upon progression only. But I know nowadays guidelines say that all metastatic CRPC we need to be looking for the germline mutations upfront because we have combinations, like niraparib with
Yes.
other combinations also. But we have not still started to practice that. We reserve it for progression only. That's in our practice.
So what about on the tumor tissue, sir? Tumor tissue?
Yeah, we do both,
Both.
somatic as well as, yes, germline. Both the testing we do. If at all, when we look for BRCA1 and 2 and other HRR, we do it on both. But once again, cost is also a big factor to be considered, right?
Yes, yes. So do you order like simultaneously or do you sequence it, sir?
No,
Like
so
germline versus somatic.
germline only first, and only then, yes, I normally look for germline, even
Yes,
in the
I
third
do.
line
I
setting.
do also
Yes,
follow the same strategy because
yes.
the germline is positive, no need to
It's
test for
positive, no need to look at the
on the tumor tissue.
somatic. Yeah, that's right. So it makes sense that way. Look for germline only.
So as I mentioned, so BRCA2 is the most common mutation found. So germline accounting for 8.8%, somatic is only 7.7. So the PROPEN trial used CRPC patients with HRR mutation. So they basically segregated patient to cohort A and cohort B. Cohort A includes patients with BRCA1 and 2 mutation or ATM gene. The rest of the other genes are included in the cohort B. So they were randomized in 2:1 patient, either to use either olaparib or physician's choice. The primary endpoint being radiographic progression-free survival. So coming to cohort A, it produced like significant kind of 3 months benefit PFS, that is 7.39 versus 3.5 with a significant p-value for cohort A alone, that is patients with BRCA1 and 2 and ATMG. For if cohort combining both A and B, it improved like modest benefit only. The magnitude of benefit comes down if you add the other genetic mutations. But still it is statistically significant. So coming to deficient MMR or MSI, so it is seen in around the patients 2.7%. So the data comes from Keynote 016, where all these patients with deficient MMR were given single agent pembrolizumab, 200 mg once in 3 weeks. Yeah, so I would like to conclude with the take-home message. Like first, we should ask like what is the treatment received in the metastatic hormone-sensitive prostate setting. Then accordingly, we can choose the agents. If it is ADT alone, docetaxel for symptomatic patients or visceral metastasis, and hormone agents for asymptomatic or mildly symptomatic agents. So we have to avoid enzalutamide in patients with seizure disorders and avoid abiraterone if the patient has heart failure or uncontrolled diabetes. Then post ADT plus docetaxel, so they consider hormonal therapy or cabazitaxel rather than re-challenging with the docetaxel. So they're recommending to avoid the ART sequencing with ART.
That's right.
Yeah. That's it, sir, from my end. Thank you.
Very good. Thank you.
Other panelists, would you like to add any other points? Like,
at any point, we should not forget ADT. We tend to, that is always there.
Yes,
no,
even if they progress, we should continue ADT. That is the backbone
correct,
of the treatment.
Correct. That's right. That's like the background music that goes on.
Yes, also about the role of bone modifying agents for
bone modifying, exactly. Skeletal metastasis. SREs, denosumab. Yeah.
It's an important point. So there is a benefit of adding a bone modifying agent, the hyaluronic acid, denosumab in this setting.
Yeah.
It's not proven with hormone sensitive prostate cancer. So do you use like a bone modifying agent in metastatic hormone positive, hormone sensitive prostate cancer?
Hormone
Any
sensitive, I don't know.
particular group of patients where you use bone modifying agent?
See, actually, ADT itself, they say causes, bone events. So if there is a high risk, probably, but maybe strictly speaking, we got to be doing a DEXA scan and looking at the risk.
Prostate is usually known to
yes.
create a lot of sclerotic lesions. I still wonder, should we regularly use denosumab or bisphosphonate for all the bone metastasis of prostate?
Lytic lesions, we should.
Unless if SRE or pain or something,
Yes.
There is trials says that routine use of denosumab have resulted in some survival improvement, but routine uses, other than if not a lytic lesion, if there is no impending fracture, should we use, if no osteoporosis found for all these patients, should we use bone mineral density increasing agents?
And metastatic, like metastatic CRPC definitely use. Like,
but not in hormone sensitive.
Yeah. In hormone sensitive, if they have extensive skeletal metastasis, then only I go for. Otherwise, I will be using like prophylactic dose, that is once in a year 5 mg dose of
Even if the extensive skeletal metastasis is purely sclerotic, no lytic component, still you tend to use?
Yes, they're symptomatic pain, so I tend to use bone modifying.
The risk of bone events is high.
Yeah, high.
Then you can.
Okay. Thank you so much, Dr. Ravi, sir. It was an excellent and insightful case presentation. Indeed, it was very informative as well. Now, I would request Dr. Arun, sir. Dr. Arun, sir, are you there, sir? Dr. Arun Ramanan, sir?
Yes. Yeah, I'm here.
Sir, would you like to conclude the entire session of the treatment for metastatic castrate-resistant prostate cancer?
Yes, prostate cancers as such, we initially thought like our role is very minimal in managing prostate cancer because most of time it will be managed with a urologist unless it is castration resistant prostate cancer with disseminated metastasis. Our medical oncologist role for all these 2 decades are very, very less. Now with the past so many advances in the field of the androgen receptor inhibitors and other hormone agents and newer drugs other than taxane, we have got the cabazitaxel and other drugs into the armamentarium to play with. With that kind of therapy, our role is, we are getting more areas to handle within prostate cancer. So one among is this castration-resistant prostate cancer. But now with all the effective strategies in the managing the castration-sensitive prostate cancer, if upfront it is not a castration-resistant prostate, then we have a good time period or more delay in happening of this castration resistance with all the effective drugs to manipulate there in the hormone sensitive phase. So hopefully the next speaker may elaborate on this hormone sensitive prostate cancer to treat with, and we can understand more on this.
Yes, sir. So with this, we would like to move on to the next case presentation. And the next case presentation is on the topic that is castrate sensitive. One second. It is on castrate sensitive prostate cancer. How do I treat today? And the moderator for the second case presentation is Dr. Ilavarshi Vanidasane, Consultant Medical Oncology, C Square Cancer Care and Research Center, Pondicherry. And the panelists for this case presentation are Dr. K. Chandralekha, Consultant Medical Oncology, VS Hospital, Chennai. Dr. S. Suresh Sir, Consultant Medical Oncology, Apollo Speciality Hospital, Chennai. Dr. Kumanan J, Consultant Medical Oncology, KIMS Nagarcoil Institute of Medical Science, Kanyakumari. Dr. S. Lingeshwaran, Consultant Medical Oncology, Coimbatore Medical College Hospital, Coimbatore. Over to you, Dr. Ileshwari ma'am. Ma'am, are you there?
Yeah.
Yeah, ma'am.
Is my slide visible?
Ma'am, can you? Yeah, it's visible, ma'am.
Good evening, sir. Good evening, all.
Good evening, madam.
So, the next few minutes we'll be discussing castrate-sensitive prostate cancer. So here, like as we discussed, the focus of this session would be to discuss on 3 or 4 major points, as in the assessment aspect. Second, how do we stratify our patients? Third, in how do we, what is our rationale in choosing the regimens triplet versus doublet? And the final discussion point would be based on the bone health management of a prostate cancer patient. So Dr. Kumanan sir is not available, I think, isn't it?
Yes, ma'am. He has some emergency, so he's not able to join us today.
Yeah, sure. So coming to the clinical case scenario directly, a 62-year-old male businessman, former smoker, with no known comorbidities, has presented on July 24 with back pain and fatigue to ortho OPD. MRI spine was done and that showed suspected vertebral mets, following which a PSA was done and the level was 169 nanogram. So hence he was referred to urology department. In urology department, DRE was suggestive of a hard prostatic nodule. The MRI pelvis was done that showed enhancing prostate lesion, Pirates 5, with a bilateral seminal vesicle involvement, capsular breach, and external node in. So what would be the next line of metastatic workup? Here, generally, the discussion is about whether how many of us will stick with just conventional imaging versus would we want to go for PSMA or PET scan for all the cases. Dr. Lingeshwar, would you like to add on that?
Yeah, ma'am. Not for all cases. Yeah, PSMA PET there would be definitely would be a logistic issue. First of all, ma'am, PSMA PET won't be available in all equip center at least, ma'am. Like in Coimbatore, we don't have PSMA PET in attached to our institute. So if at all PET is available, definitely we can think on upfront. We can go up with your PSMA PET CT, ma'am, just to know the burden of disease, because the burden of disease straight away guides your treatment in metastatic castration sensitive cases, ma'am.
So Dr. Suresh sir, would you generally go for conventional, convinced with conventional imaging, or would you want to go for nuclear image?
No, I would prefer to have an PSMA done even upfront.
Yes.
So maybe the institute where I work, and also because now affordability and the availability is also there. So I would prefer to have an PSMA update upfront.
Good. Okay. Chandralekha ma'am?
So I would go with PSMA only. So it is a one point solution for getting all the information together as whole, ma'am.
Great, good. So basically, as a panelist have told, wherever it is available, we would prefer for a PSMA scan. But it's not a must, like we'll have to do a PSMA scan like Lingeshwar sir. Even in my part of town in Pondicherry, they'll have to travel to all the way Chennai. If the patient has any back pain or fracture, they won't be able to travel. So we'll have to manage the patient with conventional CT and a bone scan in most cases here. So the patient turned out to be a metastatic prostate cancer with bone mets. So I would like to know, out of 100 patients, how many metastatic cancer patients, de novo sensitive patients do we see in our practice versus how many M0 castrate sensitive de novo patients we see?
M1 around, because of the main, because this question, there may be a lot of bias, ma'am, in answering this question upfront, because lot of cases upfront they are managed with urologist, first of all. So a proportion of cases who are to be diagnosed as CSPC is turning out to be CRPC when they reach us.
Yeah,
so mostly CRPC patients we are seeing in our practice, at least in our OP. These castration sensitive patients are being managed by, till now, even though we are speaking with the drugs and lot of trials of CSPC, till now lot of urologists are managing your metastatic castration just with a just with the bicalutamide and zoldonate. They are managing. Lot of cases are still being managed by urology. So major chunk of cases belongs to CRPC group only, at least in our institute, ma'am. In which institute which I have studied in Madurai Medical College and also here in Coimbatore.
Yeah, that's a sad reality. As we go away, we get cases only after they become resistant.
Yeah, man.
So regarding risk stratification, as we already discussed, it is basically the guidelines is based upon two trials, charted criteria and latitude criteria. In charted criteria, high volume disease is defined as visceral metastasis, and if patient has more than 4 bone metastasis, where one is beyond vertebral column or pelvis. In latitude, if there is more than 2 risk features, which consist of either Gleason score more than 8 or 3 or more bone mets or visceral mets, is considered as high risk disease. So both these trials used conventional imaging, a CECT chest, abdomen, pelvis with bone scan. So wherever PSMA scan and PET scan is there, it is really nice to pick up some early sensitive lesions. But again, the criteria for definition of high volume and high risk is based upon conventional imaging. So following the imaging, patient underwent a trust-guided biopsy, which showed acinar adenocarcinoma high grade. Following which he underwent a PSMA PET scan, which showed pelvic nodes, retroperitoneal nodes, multiple skin lesions in ribs, vertebral body, pelvic bones, and pleural-based deposits. And now, since he became metastatic, he was referred to a medical oncology department. So according to our definition, patient falls under high risk and high volume disease. So he's a 62-year gentleman with ECOG PS2. So what else would we like to do in this particular patient after he reaches our department, sir? Lingeshwar, sir, would you like to add? All of us can add.
Ideally, for metastatic CSPC, not routinely we are. I think nothing else in this patient I need to guide more. Yeah, ma'am.
Okay, perfect. Suresh, sir?
No, I think I'll be happy to go ahead and start the treatment, even though guidelines recommends to do an HRR upfront. I would still reserve it, start the treatment, and then do it once there is a progression. Maybe that can come up with a new HRR or any other NGS, which can come up with a new genetic mutations also.
Yeah. The disease state is at the point of progression. Chandralekha ma'am, are you comfortable with this imaging to start the therapy?
Yes, yes, ma'am. As Suresh sir told, like I would also prefer to go with for the diagnostic part, as this one is enough. Maybe after that we can go with the chemo workup or pre chemo workup we can go. But the HRR panel, as told, I would reserve for the future thing, though it is mentioned upfront.
Yeah, great. So here, after our routine evaluation, cardiac evaluation was done, patient was, since he is fit, we decided to go ahead with triplet regimen since he is a fit individual and falls under high volume and high risk disease. After this few slides, I would be discussing on various trials. And since he's in castrate sensitive disease, denosumab or bone health is not added in terms of survival benefit or SRE for him, which is not recommended. Usually in my practice, I would go based upon the osteoporosis status in case-to-case basis. We'll be discussing about it a bit later. So, as discussed regarding NGS, molecular profiling of upfront de novo case, though the guideline suggests, most of us do not practice it. We reserve it for at the time of progression to study the biology at that time. Is there any difference of opinion with other pathologists here? Do we, sir, Ramanan sir, Prem sir, do we do it upfront in our practice or do we keep it at the time of progression?
No, in our practice, as I earlier pointed out, it is only on progression. Though the guidelines, yes, we have guidelines stating that upfront all metastatic disease needs to be, even NGS and germline testing and all that, genomic testing. But we reserve it for later lines upon progression.
More of patients' resource management. We'll have to preserve their
Exactly.
Okay, thanks. So, as the guidelines suggest, post imaging and PSA, the guidelines suggest somatic testing upfront. But in regular practice, most of our medical oncologists, we preserve it in later part. And based upon their risk stratification, we would choose a therapy. So if it's low volume, So these are the table which narrates the clinical trial in an upfront metastatic patients. So the two trial which studied about radiotherapy in metastatic castrate-sensitive prostate cancer is Stampede H and HORA trial. Charted also has few mention about this. So in the conclusion here is radiotherapy does not improve, does not provide any survival benefit in metastatic cancer patients. Though in Charter trial, there was a subset of population who benefited with radiotherapy. Those are predominantly low burden and low volume disease patients. Now coming to addition of chemotherapy, ADT doublet therapy, Charted and Stampede demonstrated HR benefit of 0.63 and 0.81. Latitude, Stampede and Enzymate, Arches and Titan studied various ARSIs along with ADT. So all showed survival benefits. There is no, most of the trials have cross-trial, it's mostly cross-trial comparison and there is not much benefit of one over other. How do we select has been discussed in our previous session elaborately, and how do we sequence it, we can discuss it shortly. The latest are the triplet trial where they found out apart from ADT and ARSA, adding chemotherapy or triplet has found to have good survival benefit of up to 20 to 30% of reduction in death in arsons and PEACE-1 trial, especially in high volume and high risk disease. So benefits of doublet therapy in metastatic castrate-sensitive prostate cancer. This table here shows the survival benefit across various trials when compared to doublet with ADT. This is has been for long now, and as a general medical oncologist do not stop with ADT unless the patient doesn't reach them. Apart from it, recent trials here, the triplet has shown even more benefit when compared to doublet, especially in high volume and high risk population. The OS results of Latitude trial shows significant OS benefit of 53 months versus ADT alone, which is 36 months. In arches, when enzalutamide added with ADT versus ADT alone showed median survival survival of around 0.66 HR, and Titan trial showed around around 30% benefit. So, sir, how do you select this? Again, this is a common discussion which we have, but in your general practice, what is the population you see, and what is your most common first line therapy in terms of ARSIs? Lingeshwar, sir?
Yeah, ma'am, based on patient criteria only, ma'am, considering age, side effect, considering the comorbidities, definitely we have to think of comorbidities because apalutamide is more prone for enzalutamide is more prone to cause hypertension. No, any patients because nearing above 60 or 65, they may be having comorbidities. Definitely, we have to look into comorbidities to select this, ma'am. There is no clear-cut stringent criteria how to sequence this apalutamide or enzalutamide. So based on that is that the therapy has to be sequenced based on patient.
So in your practice, what do you see, sir? What is the type of population you see more? I mean, what are the regimens like? Which are your comfortable ones, like in your set of patients?
Yeah, at least for low volume disease, straight away I can go for ADT combined with your chemo dosi, or I can I used to prefer abiraterone rather than your apalutamide and enzalutamide. Yeah.
Okay, sir. Dr. Suresh, sir, in your practice, what do you generally go for, sir? What is your...
Yeah, so as we said, if the patient has some cardiac issues and uncontrolled hypertension or diabetes, because the steroid which we need to give along with abiraterone. So I'll be thinking about choosing enzalutamide over abiraterone.
Okay.
Suppose if the patient has got an neuropathy or CNS symptoms, or a patient is a known seizure patient, and then I would be happy to have to abiraterone. And apalutamide, as of now, I have not used in much of those patients. And we know that, again, neurocognitive issues will be an issue in apalutamide. DARA, as of now, it is always with docetaxel, but convenience-wise, as dosi, we have used dosi as water, so we know what to expect out of dosi. And so when we have an young patient, I would be preferring to have a dosi along with abiraterone. And in patients, if they are aged, elderly, and then I would be happy to go ahead with the enzalutamide with ADT. So that's how I choose my doublet combinations.
Good, sir. Sir, in your practice, like have prednisolone been a deciding factor to not to go for abiraterone in any case? Never, isn't it?
No. I don't think about adding prednisolone because 5 mg BD is fine, and even if we decrease the dose to 5 mg OD also, we don't have the other side effects coming. So prednisolone is not a concern for me.
Chandralekha ma'am, would you like to give your point of view in this? Like,
Yeah, ma'am, like if it is a fit individual, like less than 60 or at least up to the cutoff of 65, with the ECOG performance status 1, I would definitely go with the docetaxel and abiraterone. And if it is an elderly individual who is or frail or more than 70, I would consider to use the oral drugs. Among them, considering between abiraterone and enzalutamide, I would prefer to use abiraterone first than enzalutamide because per se when the patients are taking those drugs, the fatigue part is better with the abiraterone. Then the rest of the side effects, as sir has mentioned, that also need to be considered from our point of view. But otherwise, abiraterone is fairly well tolerated by the patients.
Yeah, agree. So yeah, we have 4 drugs in our armamentarium where we know about docetaxel and least expensive and a fixed duration of therapy. In an otherwise fit patients, we would opt for docetaxel. Abi and Enza, based upon patients' comorbidity profile, we can choose based upon our comfort. Now, this slide here shows the role of triplet combination therapy in metastatic castrate-sensitive prostate cancer. PEACE-1 and ARSENS trial. PEACE-1 studied docetaxel ADT versus abiraterone with docetaxel and ADT. And the co-primary endpoints was PFS and OS benefit. It's 2 into 2 factorial design study. ARSENS studied darolutamide with DOSI and ADT versus placebo and ADT and DOSI. The primary endpoint was survival OS benefit. So the picture here beautifully shows the survival benefit of triplet over doublet regimen in both PEACE-1 and ARSENS trial. After a median follow-up of approximately 4 years, there is the OS, the median OS is not reached in the triplet arm, whereas it was 4.4 year in the doublet regimen. So coming to the side effect profile of triplet versus doublet, it's predominantly a fairly manageable side effect, as everyone would agree. Most of them are neutropenia, hepatotoxicity, and hypertension in PEACE-1, and in ARSENS it is predominantly neutropenia and hypertension and anemia. In our practice, what do we generally see, sir, in toxicity part? I generally see a lot of fatigue in these patients. Lingeshwar sir, what do you see in triplet regimen in your practice?
Yeah, ma'am. Fatigue, excess fatigue, musculoskeletal pain, especially, ma'am.
Yeah.
Especially musculoskeletal pain.
Yeah.
Definitely.
Suresh sir and Chandralekha ma'am. So is there anything which we would do? Do we have Suresh sir? Chandralekha ma'am, would you like to add here?
Yeah, obviously, giving a triplet regimen, it's known that the patient will complain of fatigue, and but we are also selecting the patients. Only those patients with good performance status we are selecting, and so they fairly tolerate triplet regimens.
So mostly it is grade 1, grade 2, isn't it? Or do you
Yes,
come across?
yes, grade 1 and grade 2 only, because we are selecting the patients and giving, so it doesn't actually matter much.
Okay. So coming to docetaxel, do we stick with 3 weekly or do we go with the 2 weekly cycle in most of the cases when it comes to triplets, sir, in your practice, Suresh sir?
Sorry, I was another call. No, I would prefer to have a 3 weekly schedule, and I didn't find much differences or more side effects in a fit first line DOSI triplet therapy. Patients are able to tolerate that, except for some patients who might show some high reactions. They might not tolerate DOSI, like hand and foot skin peelings, and the diarrheas might be the common complications of docetaxel. We don't know which patient is going to get those complications, but if not, they will be able to tolerate the triplet therapy.
Now, coming to benefits of triplet therapy in PEACE-1, apart from increased LFT primary toxicity with the addition of abiraterone, uh, this was the side effect profile. There was mild increase in congestive heart failure and some electrolyte imbalance, which might also contribute to the fatigue component of few of our patients. In Arsen's trial, a slight increase in incidence of hypertension, which was observed, and there was low incident of neurocognitive issues with darolutamide. So the criticism of few of the criticisms with triplet therapy is the complicated trial design of PEACE. So some told us comparator arm should not be only docetaxel and ADT. That might not be a very strong point when we have data that docetaxel, abi, and denza all comes under category 1. So high volume, high risk disease subgroup. Again, that was an exploratory analysis, but then the result, the survival benefit, the charts were showing beautiful results with triplet when compared to ADT, especially in high risk and high volume disease. So how do we monitor our patients? Is it with when do we want to go for PSMA scan? How frequently would you go for PSMA cancer after your triplet regimen, Lingeshwar sir?
Ma'am, as it's mentioned in the slide, there is no. I would like to do a. As long as the patient is tolerating, ma'am, there is no stringent criteria or criteria cutoff to when to do a PSMA PET while the patient is on triplet regimen. So
You stick with
it's
PSA?
up to we stick with PSA, ma'am. Yeah, definitely.
Okay.
PSA levels, ma'am. Yeah.
How
Or there
frequently
is a
would you monitor, sir?
clinical progression. Yeah, or there is if there is a clinical progression.
Okay. Okay. How frequently would you like to monitor the PSA levels, sir?
So PSA levels, maybe I do once in 2 months or once in 2 cycles.
3 months.
And I'll be investigating with an imaging only if there is a biochemical failure or there's a new complaints. Otherwise, I don't do an imaging. If the PSA is under control, we can continue with the treatment.
Okay. So regarding bone health of a patient, so as in breast cancer, before starting letrozole, we most of it's a routine practice to go for DEXA scan. The same thing doesn't happen as in routine practice in castrate specific prostate cancer. Do we generally go for DEXA scan assessment for a castrate? For a prostate cancer patient at baseline, or is it very case based? Chandralekha ma'am or Suresh sir?
No, I don't do any
DEXA scan.
DEXA scan upfront.
Okay. Sir, what is your management line in castrate sensitive prostate cancer in terms of denosumab or zoledronic acid? Is it?
Yeah, if at all there is a skeletal involvement, even if it's going to be a lytic lesion or a sclerotic lesion, I would prefer to have an bisphosphonates or denosumab. Denosumab, if at all, maybe because of the action on both the osteoclast and the osteoblast, it may be a better thing to control the skeletal-related event. So zoledronic is fine when it is a lytic lesion, we can give, but bisphosphonate only in lytic lesions, whereas denosumab can think about in both sclerotic and thing. So, and unless there is a bone mets, I don't prefer to have a prophylactic bone health management. And if at all in metastatic bone lesions, I would prefer to have once in 3 cycles. So once in 2 months or 3 months. So, and that will be only for a year. Post 1 year, I'll be shifting to once in 3 to 6 months.
Thank you, sir. Chandralekha, ma'am?
Yeah, I would also prefer
would
to give bisphosphonates or denosumab only when there is bone metastasis. So between
also for
bisphosphonates,
castrate sensitive, consider it for our own case, ma'am. This particular case presentation, who has a bone mets, falls under high risk category.
so between denosumab and bisphosphonate, I would prefer to go with the monthly denosumab when there is a high volume disease or
Then in a
number of
sensitive case,
sorry.
Even in a castrate sensitive case.
Yes.
Okay.
So usually I would prefer to go because I personally think that even even if you consider if it is a castrate sensitive, so for a few months, 3 to 6 months at least, I would prefer to give it as monthly denosumab. Then maybe I would taper the frequency of that.
Okay, ma'am.
Or zoledronic acid also if cost isn't constrained.
Okay, ma'am. Yeah. Lingeshwar, sir?
Yeah, ma'am, I will like to go with zoledronic acid, ma'am. Since this patient has a predominantly light lesion, I will like to go with monthly zoledronic acid rather than with the denosumab.
Monthly, okay.
Yeah.
So the guidelines suggest risk assessment and monitoring. Risk assessment at the baseline of ADT. DEXA scan is recommended in most of the patients to find the fracture risk of the patient. And patient who's on ADT, DEXA scan is recommended every 1 to 2 years or based upon their fracture risk, based upon the BMD score. Anti-resorptive agent in a castrate sensitive disease, so there is data supporting that addition of anti-resorptive agent might not add to survival benefit in sensitive disease, though it is recommended for bone health, decreasing the fracture risk of the patient. The guidelines suggest DEXA scan at 1 year and anti-resorptive therapy based upon the DEXA scan. So all patients who are receiving ADT, lifestyle modification is a must, as in case exercise, alcohol, limiting alcohol and smoking, and balanced training and safe movement strategies like fall prevention, prevention of slippery surfaces, and railings, etc. Apart from it, calcium and vitamins D supplementation. And for treatment of bone loss during ADT, anti-resorptive agents are recommended in metastatic castrate-sensitive prostate cancer. And for prevention of symptomatic SRE, though the data has not suggested, zoledronic acid is recommended every 12 weeks once in castrate-resistant prostate cancer. So now coming to the final part of discussion, Rilgolix. Now this comes as easy option for many patients who have to choose with injection versus orchidectomy. So in our practice, how many patients are very receptive for surgical orchidectomy versus medical castration, sir? Lingaraj, sir?
Ma'am, every time we start to counsel a patient regarding orchidectomy, it's like for convincing a patient for like your adriamycin for your breast cancer, they are more concerned about hair loss rather than your disease.
Yeah, exactly.
So definitely they are concerned about their testicles
yeah.
rather than your disease. So definitely they are very comfortable with the medical castration, Rilgolix.
True. So, HERO trial studied regarding Rilgolix versus Leuprolide for prostate cancer. The primary endpoint of the study was sustained castration rate. That is testosterone suppression of less than 50 nanogram from day 29 through week 48. The 120 milligram per day was given versus leuprolide acetate 11.25 every 3 weeks. So this chart here shows the Rilgolix was showing good castrate sustained response sustained castration rate when compared to leuprolide. And in our previous slide also, in our first lecture also, sir had beautifully shown the chart where relugolix had an early response when compared to the traditional medical suppression, medical orchidectomy. So coming to grade 3-4 toxicity, around MACE, the percentage of cardiac events was around 2.9% when compared to leuprolide, which was 6.2%. And constipation and diarrhea was a bit more in case of relugolix when compared to leuprolide, as we see in most of our oral medications. Relugolix was associated with lower rate of cardiac events when compared to leuprolide. So it showed significant symptomatic benefit after 1 month. After 4, okay. So this is our patient whom we discussed in the first 2 slides. He showed significant benefit after 1 month of starting triplet therapy. Had 4 cycles of docetaxel. His serum PSA fell to 22, and the PET scan, PSMA scan was done, which showed a partial response, and he tolerated treatment well with reduction of docetaxel to 20%. And after 6 cycle, it was stopped. What is the general duration of docetaxel we give for a triplet patient, sir? Suresh, sir? Is
Yeah,
it?
we stick to 6 cycles, but there are also studies which says up to 8 cycles in prostate.
Okay, so yeah. Chandralekha ma'am, you also practice 6 or you go up to 8 to 10? There are few who go for 10 to.
No, 6 cycles only, ma'am.
Okay. So patient is currently on ADT and abiraterone. So this slide here, understanding adverse effects with ADT, and how do we manage. Though we see this in a subtle fashion in most of our patients, we really do not treat them apart from osteoporosis. Most of our patients would complain of fatigue and some vague symptoms which might suggest of hot flashes. So according to various trials, hot flashes are very common. It can be mitigated by gabapentin or SSRIs. And osteoporosis, we discussed about fracture risk, calcium, vitamin D. Fatigue part, again, it is very common. Regular exercises has to be encouraged. Limiting alcohol and smoking also has to be encouraged. And management of other comorbidity also has to be done. Metabolic syndrome, again, when hormone patients who are on ADT, it's common. Weight gain is seen in 1 year of ADT, and other comorbid conditions also has to be watched for. Erectile dysfunction is common. Cardiovascular disease is one which we are aware and most of patients do face. Sir, I would like to know the house's opinion. Is there any particular strategy which we follow to address these issues where some patients find it very troublesome? Or do we give a break of ADT, restart, given intermittent? Do we see it in our practice, or is there anything else which we would add in fatigue for the patients who complain of severe fatigue after starting ADT? Suresh, sir? Suresh, sir? Am I lost? Hello, am I audible?
You are audible, ma'am. I think
Yes,
Farid
I'm
was
audible, ma'am.
Sorry. Lingesh, sir, could you add, is there anything else which you would monitor the patient apart from their routine thing for the fatigue part, or would you add anything?
this slide has concluded almost every side effect profile of those things.
So is there anything additional which you do in your practice which would help patients with these side effects in your routine thing?
Yeah, ma'am, I never practice like to short term withholding of those ADT and restarting. I never have that practical experience, ma'am. But we are managing the side effect profile in a metastatic PC while we are deciding whether the triplet or doublet. It's the most challenging one, actually.
Yeah. Yeah.
Very challenging one, very challenging one, ma'am. So, like, we keep on learning patient to patient.
True,
That's
true.
my personal opinion.
Very true.
That's my personal opinion. So, I have to see at least numbers, a huge load of patients to come to a conclusion, ma'am. Till I'm in a growing phase.
Yeah. Chandralekha, ma'am, is there anything apart from this which you would want to see in the patient who's on follow-up in castrate-sensitive prostate cancer? Or the same thing like to
The
add?
same thing only, ma'am. We usually follow up the recounsel on the fatigue part, and usually we don't prefer to give a break unless they complain of excessive fatigue. Otherwise, we do a routine electrolytes and cardiac monitoring also, and liver functions monitoring also.
Electrolytes, cardiac monitoring, yeah. These are must, apart from a routine bone health monitoring. So how do we monitor manage side effect of ADT? One is awareness of all the risk and presentation of heart disease, assessment of the cardiovascular risk, wherever appropriate, aspirin usage or cardiology evaluation, BP monitoring and management. C stands for other comorbidities management, cigarette and tobacco cessation, cholesterol assessment and management, D diet and weight management, encouraging exercises, and ECG and again cardiac monitoring in a routine basis. In conclusion, ADT as monotherapy is suboptimal for management of majority of our patients with metastatic castrate-sensitive prostate cancer. RT in metastatic castrate-sensitive prostate cancer has limited data where it showed improvement in survival in a very subset of population who has low volume metastatic disease. ADT should be combined with ASRS or docetaxel for patient with metastatic castrate-sensitive prostate cancer. Treatment intensification in metastatic castrate CSPC has come big way after the triplet trials has come, PEACE and ARSENS. And in patients planned for upfront docetaxel, addition of abiraterone or darolutamide as triplet has shown significant OS benefit. Thank you. Thank you. Well, thank you, sir.
Thank you.
Thank you so much, ma'am, for an excellent presentation and a wonderful discussion on the topic. Now I would request Dr. Arun sir, would you like to conclude for sensitive castrate sensitive prostate cancer as well?
Yes. So it's a very important, Doctor. Clearly, how she has explained about the management of hormone-sensitive prostate cancer. It's a wonderful talk. We do acknowledge that with the maximum possible drugs into the armamentarium like triplet therapy, we are now able to extend the overall survival for certain subset of patients who actually can withstand the therapy. But apart from that, there is is importantly we have to look on to the proper sequencing of these drugs to achieve the maximum benefit here, to get the good survival outcome at the cost of lesser side effect, because handling the geriatric patients is not easy unless we gain the confidence of those patients with lesser side effects for these kind of slow growing prostate cancer. It will be a very difficult task to prescribe them all the chemotherapies and other even hormonal therapies, because as mentioned, these side effects are able to limit the activities of daily living and other parameters which can easily deteriorate the scales of geriatric patients. So careful selection of patient for each therapy is very important, and proper sequencing may help us to get the maximum benefit out of all the anti-prostate cancer treatment agents. So various risk stratifications and various guidelines are there to categorize these patients based on their volume of disease and the rate of PSA velocity. So with all the parameters and along with the performance state, age, and comorbid conditions, we have to properly select the key drug. Now plenty of drugs into the armamentarium. With this 1 decade, we have seen so many drugs added to that treatment. Along with that, we have even extended roles with PARP inhibitors and immunotherapy. The castration sensitive phase is very important. Only if we are able to extend it, we can delay the occurrences of resistant phase for most of patients. So we have to catch the window properly. So it's a very important window to work on. Anyway, it's a good talk, a very informative one.
Thank you so much, Dr. Arun sir, and our both moderators for the case presentation. Now I would request Mr. Prasad Amle to go for the vote of thanks.
Thank you so much, Anjana ma'am. So I'm happy to share that we have around 265 live audience attending this session. So all the delegates, speaker, moderators, directors, all I want to thank you for giving the time in this session. I would also like to thank Mice Ideas for organizing this session, and Happy New Year to all in advance. And I conclude the session with that.
On
Good
the
evening.
outside, I would directly like to thank the Samrath team for giving me this wonderful evening academic discussion. And I've seen a lot of young oncologists coming in, throwing their academic ideas here. It's a wonderful platform. Kindly continue the same kind of academic activities in future too. Thank you.
Thank you so much, sir.
Sure, sir. Thank you.
Yeah, thank you, sir.
Thank you, everyone. Wishing
Thank you.
everyone
Happy
a
New Year
happy
in
new
advance
year.
to everyone.
Yeah, thanks.
Thank you.
Happy New Year.
Thank you.
Happy New Year.
Yeah, good night.